talking about lymphedema care and management in this webinar today. So we'll go ahead and start right away. As previously mentioned, as far as disclaimers, that this is all educational only, and nothing we say today is to be taken as medical advice, and you want to consult a proper medical professional. And I have no disclosures today and no conflicts to report. One second. All right. So the objectives for our webinar today is just to explain about the lymphatic system function and the pathophysiology of lymphedema, so that we can support, accurate clinical understanding and patient education. We want to identify common causes and risk factors in early signs of lymphedema, so that we can support timely recognition and intervene. Talk about some evidence-based strategies for managing lymphedema, including proper compression, exercise, skin care, infection prevention, and then just overall just integrating lymphedema assessment findings into our care plans, including things like monitoring and documenting properly, and just good patient education, and knowing when to refer to a specialist when it's appropriate. So just an overview about the lymphatic system. So it's one of the three parts of the vascular system. Just as a review, the vascular system includes the arterial system, the venous system, which are popular, and then the lymphatic system is kind of like the third rail. So if you think about it, as the arterial system brings all the oxygen-rich nutrient blood to your interstitial tissues and ultrafiltrates that out. And the venous system ultimately takes most of that fluid that ends up in that interstitial system back towards the circulatory system. But a significant amount of stuff that gets filtered from the arteries ends up getting put back into circulation by a lymphatic system. So if you think about it, it collects and transports all that excess tissue fluid from the interstitial fluids back to the venous system, maintains normal plasma volume. By doing that, it absorbs up to 2 to 3 liters of protein-rich fluid every day. It helps prevent edema, because it has built-in reserve to try to balance out fluid in your system. And it also has some important functions in the body by removing toxins, waste products, and cellular debris from tissues, while protecting your body from infection. It's part of, important part of the immune system, because it produces a lot of the antibodies that help protect your body overall. And then just to define lymphedema, it's a chronic condition, characterized by abnormal swelling in the arms and legs due to damage to that lymphatic system. The swelling is usually caused by excess accumulation of that protein-rich fluid in the affected limb. The swelling can range from very mild swelling to very severe, so much that individuals are unable to function properly just because of the dysfunction they can get from lymphedema. So it's a very significant problem that needs to be identified and managed properly. Then just talk a little bit more about epidemiology. So just like we mentioned before, is that third component of the vascular system, which is very important in returning fluid back to the system. Chronic lymphedema itself, it has no cure. So when someone gets to the stage where they have chronic lymphedema, it's just a lifelong long-term management problem, which is really important to have buy-in from the patient to manage it properly. It's commonly undertreated because there's not a lot of very specialized people who treat it, and lymphedema clinics and things like that. And it's something that we see a lot in the population that we see, as clinicians with ProHealth One. So again, very important to manage this properly. It's a very, very widespread problem. It affects about 3 million people in the United States. And we'll get to this a little later, but like secondary lymphedema itself, from malignancies, a significant portion of that is usually patients with breast cancer or gynecologic cancers, but even patients with melanoma, head and neck cancers, and genitourinary cancers, constitute a large part of the population of patients who present with secondary lymphedema. So it's really a big problem. More about the pathophysiology. So as we previously mentioned, that major function of the lymphatic system is to return fluid and protein from the interstitial space back to the vascular system. And when that malfunctions, we get lymphedema. Um, that accumulation of excess lymphatic fluid in the system causes an inflammatory response, which usually leads to extra fat deposit and basically extra fat generation and deposit in the tissues, which kind of causes a lot of the characteristics that you see with lymphedema. Usually things like fibrosis and the hypertrophy of adipose tissues, which will present as that enlargement of the limb, and then the skin changes that you typically see. So a lot of times patients, depending on what stage of lymphedema they would have, will present with soft pitting edema. As it kind of progresses to later stages, you start to see more of the fibrosis and the hypertrophy. That is common, unfortunately. That usually by the time you diagnose, it's usually kind of advanced those later stages. Primarily, if you divide lymphedema into two types, there's a primary and a secondary type. Usually, this just has to do with whether it's kind of more of a natural occurring reason why you get the lymphedema versus if you had something that kind of happened later on that causes it. So primary lymphedema usually, it may be congenital, something that's present at birth. Some people develop it later in life, some people very early. If it develops during puberty, it's usually called precox lymphedema. If it's later in adulthood, they call it tardive lymphedema. And primary lymphedema would usually affect the lower extremities, but you can also have it in the upper extremities all the way up to the face. Secondary lymphedema is usually the one that's acquired by something that kind of happens mechanically. So you want to think about people who usually have radiation treatments or surgery from some kind of cancer. So common in patients with breast cancer, lymphoma, and melanoma, or gynecologic kind of surgeries. And it usually results because the treatment damages the lymphatic system in some sort. So it prevents it from draining properly, leading to the lymphedema. Another way that we also categorize lymphedema is in stages. And this usually just has to do from how severe it is. So there's 4 stages from stage 0 all the way to stage 3. The first 2 stages are usually reversible, while the last 2 are usually irreversible. And then within each stage, you can also categorize them as minimal, moderate, or severe, depending on the limb volume. So it's considered minimal if it's less than 20% increase in size from baseline, moderate if it's 20 to 40% increase in size, and then severe it's greater than 40% increase in size. So we'll just go quickly through those 4 stages. So stage 0 is usually the first stage. Like we said, it's one of the 2 reversible stages. So this is subclinical lymphedema. It's usually the kind that is still not very, very clear what's happening, but a lot of times this is when the patient usually can complain usually of some heaviness or achiness in the legs, but then they don't really have a lot of physical changes. So this may last actually for months or years before you really get edema to occur. But it's usually, like you say, you don't really see a lot of symptoms, but then it's usually something that's there. Stage 1, on the other hand, usually start seeing a little more symptoms. So they start getting pitting edema distally, kind of closer to the feet. And that's usually because that lymph fluid with high protein content starts to accumulate more. They would tend to get the edema to go away when they elevate the limb, and at this point too, they also have a negative or borderline stammer sign, and we'll talk a little bit about stammer sign, but it's just a physical exam finding that you can find in patients with lymphedema. Usually at this stage, you usually have that fibrosis happening. And like we said, it's spontaneously reversible, where it can kind of come and go. But when you get to stage 2, which is irreversible at this point, you usually kind of get, minimal, not really pitting edema. But, the limb no longer reduces in that edema when you elevate it or when you do other kind of conservative measures. Usually you get a positive stammer sign at this point. You get more pronounced fibrosis in the skin. you get that hyperkeratosis, and then you can start to see um, the skin kind of present with this rough cobblestone appearance, which we call papillomatosis. And all of these changes usually they're not reversible anymore at this point. Then lastly is that stage three, that fourth stage of lymphedema, where you kind of have a little bit more pronounced physical findings. You get that massive limb distortion, which we call lymphostatic elephantitis. Kidney edema is not really present at this point, but that fibrosis has really progressed. You get increased kind of skin thickness, and a lot of other skin changes that really are concerning to patients at this point. This is usually also the point where you start to see more ulceration happening. So next, we'll just talk about some things to think about with lymphedema, as far as other conditions that can kind of look like lymphedema, but it's really important to differentiate them. And the very obvious one is venous edema, which very often gets confused with lymphedema. So with venous wounds and things like that. The I think the most common way that you usually think about it is that people with venous edema, they present with a little bit more pain. And one key thing that they usually have is that elevation would tend to really resolve the edema, which doesn't really happen with lymphedema. So that's usually kind of the key thing to think about. Another condition that's very kind of similar to lymphedema, but it's not, it's called lipedema, which is really a condition, a chronic condition where you get a lot of fat deposit in the limbs. The key difference that you usually see with lipedema, which you wouldn't see in lymphedema, is that it can happen, just like lymphedema, it can kind of happen in upper lower extremities, but with lipedema, it usually spares the feet and the hands when it happens. So you don't get that swelling in the feet and the hands that you would get typically with lymphedema. Just to go through a few differences or some differences that you see between lymphedema and lipedema. Risk factors for lipedema is usually thought to be hormone related. So it's something that's hereditary. It's kind of more common in females and kind of associated with hormonal changes. So you can kind of see it in people with in pregnancy often. Also kind of risk factors, and other risk factors for that is having gynecological surgery and major trauma. While with lymphedema, kind of risk factors is more like long-standing venous disease, obesity, and then disruptions in the lymphatic system from chemotherapy and radiation or lymph removal from surgeries. And then the distribution, like we kind of mentioned before, with lipedema, you kind of see it involving the limb. You usually go from the ankle to the groin, or from the shoulder to the wrist, but it usually spares the hands or feet. You see that bilaterally, it's kind of symmetrical, and then ulcerations are not very common in lipedema. But in lymphedema, it goes all the way from the toes to the groin. It would involve the hands all the way to the shoulder. Any extremity can be involved, and sometimes it's unilateral, bilateral. Characteristics of lipedema too. It's kind of more soft tissue accumulation of fat. They're usually very painful in palpation, and they usually bruise very easily. You don't usually see a stemmer sign with lipedema, and cellulitis is also very uncommon in lipedema, as opposed to lymphedema, where you kind of get more of a cobblestone appearance. You get a lot of skin and soft tissue changes, which you don't see in lipedema that much. You get peanut edema early on, but then usually later on in the later stages, like we mentioned before, you get more like that indurated, thickened skin. Edema that doesn't increase with elevation. You get more weeping with this, and then cellulitis is very common in lymphedema. The management for lymphedema and lipedema can be very similar. Usually involves things like good weight control, good exercise, compression therapy works for both of them, and just very good patient education. With that, I think we'll move to the first polling questions. So we'll give people some time to answer this.
We'll give just about 10 more seconds for everyone to answer.
Oh, that's good. All right. So that's good to see. Most people feel they are somewhat confident with this. So that's a very good place to be able to start. So hopefully, as we talk a little bit more about lymphedema here, we can get that confidence higher. Megan, we okay to proceed?
Yep, go ahead.
All right. So just moving on. All right. We're going to go over some aspects of, just assessment of lymphedema. So again, talk about risk factors for lymphedema. Again, this will have to do with a lot of things that kind of disrupt the lymphatic system. Um, so surgeries that kind of interrupt lymph nodes, big risk factor. So lymph node removal, taking more lymph nodes than taking just one definitely increases the risk. So axillary lymph node dissection is just taking out all lymph nodes versus just taking one with a sentinel lymph node. Having multiple surgeries obviously destroys the system. Extensive surgery, radiation, chemotherapy, DVTs are a big one too, because it just causes congestion in the venous system, which feeds into that lymphatic system as well. Chronic venous insufficiency, different kinds of trauma, obesity, infection, and then obviously family history contributes to your risk of having lymphedema. And then with the assessment of lymphedema, another important step is, when you first see the patient is doing very good measurements of the limb. This is just important as you treat the patient just to be able to calibrate how well you're doing. And to do this, it's just important to use non-elastic tape and measure the circumference of the limb in multiple areas. So you should do it in a way that's easily reproducible, and then just measure apart every 4 centimeters, and just document that properly so you can track how well you're doing with your treatment. And then another important component of assessing patients with lymphedema is their pain assessment. Just having it, keeping in mind that pain can arise from multiple sources. It could be from the original reason why they're having the lymphedema. So it could be coming more from the infection or the inflammation, or the radiation itself that's causing it. But it's just important to differentiate it and tease that out, so that you're managing that properly, just as you kind of assess and treat the patient with lymphedema. So, in that regard, a very thorough assessment is very essential, and documenting that very properly. Um, you know, um, there is no single predictable pattern to the pain for lymphedema as well. So you can't always just expect that you would get the same response from every patient, because some people would feel more pain than others. So it's just gotta know that it's a dynamic thing. But the whole important thing about it is just to make sure you do a very thorough assessment, make sure you know exactly where the source of pain is, and manage that properly, just so you can get good adherence from the patient. Another important aspect of the assessment is just the psychosocial part of it. Just knowing that patients with this, it can be very disfiguring. It can be something that causes anxiety and depression, and it does change the patient's life. So it's important to be very sensitive to that, and knowing how that individual handles this diagnosis, knowing what kind of support system they have, knowing what kind of coverage they have, so that you can tailor your treatments properly. But it's also a very important aspect to incorporate into your plans when you're taking care of a patient with lymphedema. And then, as far as diagnosis, the diagnosis really is usually done with a very thorough history and physical. So it's a very clinical diagnosis for lymphedema. But there exist some imaging studies that you can do. The gold standard for lymphedema, it's an isotopic lymphoscintigraphy, which is just injecting a radionuclide dye into kind of the distal end of the lymphatic vessel, and then just trying to capture that with the imaging to see basically where you're having disruptions. It's an expensive study. It's not something that, is routinely done, but it's available. And, if you're thinking of it more from an academic standpoint, there is a test that you can do for lymphedema, which will be lymphoscintigraphy. Another diagnostic test you can do is an MRI, which you can do to kind of evaluate the lymphatic trunk anatomy and see where any obstruction is occurring. It basically kind of show you a honeycomb pattern in the subcutaneous tissue. From where you have disruptions in the flow of lymph and where you have fibrosis, so you can actually see on the imaging to make an official diagnosis from that standpoint. So that's also something that's available, but typically a very good physical exam is all you need to diagnose lymphedema. And then moving on to clinical manifestations. Typically with lymphedema, what you will see is just early on, especially, you see pitting edema. They're usually not painful in those early stages, but then it becomes non-pitting as the condition advances and kind of gets to those later stages we mentioned earlier, when you kind of get more of that thickening of the skin with the fibrosis and hypertrophy. Usually, it kind of starts distally in the feet and then kind of progresses up towards kind of the proximal part of your legs and the rest of your extremity. Usually we'll see some erythema and that cobblestone appearance on the skin. Patients usually complain more of an achiness or heaviness in their limbs. That just makes it difficult to walk around. Not typically the pain, but then it's just that achy, heavy feeling in the extremities. And then, like we mentioned before, the edema itself does not improve with elevation. So usually you have to rely more on compression. And then that was that big distinction with more of a venous edema, which will improve with elevation, but with lymphedema, it does not. And then again, you see that fibrosis in the skin in the later stages, and then you see that hyperkeratosis, which is just that gray patches in the skin and that scaly appearance of the skin that's just caused by excess deposition of keratin in the skin. And then a common thing that you also see with people is just that weeping. It doesn't seem to always come from like an open sore, but then they just get this very, very small openings in the leg that just kind of like slowly seep out and weep. So that's very, very common in lymphedema. We mentioned this several times before, but a stammer sign is an important physical exam finding in lymphedema. So the way you usually perform this is just at the base of the second toe. And then if you're evaluating the upper extremity, it will be the middle finger. You just want to pinch and lift a skin fold. So if the skin lifts up, it's considered a positive stammer sign. And it's usually a good indication that they likely have lymphedema, and you have to address that. So if the skin lifts up, it's a positive sign. If it does not, it's a negative sign. There are no false positives performing this test. So like I mentioned, a positive stammer sign is, it indicates lymphedema, and, the patient basically should be, at that point, should be referred to a lymphedema specialist or should be, treated properly for lymphedema. But it's also important to know that even if they have a negative sign, you still have to, rely on, those other parts of the evaluation we talked about. It doesn't mean that they don't have lymphedema. It's just they have a negative sign. You have to kind of rely on the rest of your exam to still evaluate whether they have edema. Next, we're going to talk about lymphedema complications. And this is, where we usually kind of step in as one specialist or people who deal with lymphedema, because we always see these people when they're having complications. So like we've alluded to in the past, things you can kind of have with lymphedema to address pain. It causes significant disability. Cellulitis and erysipelas are very common psychosocial issues with depression. A lot of, like we mentioned with cellulitis, another big part that you also see with this is fungal infections. And then it's also usually very, very disappointing because the infections are very, very recurrent. So, you always kind of notice that you're kind of going through cycles where you're treating these infections in people with lymphedema. Even when they improve, they tend to come back. Um, Again, breakdown of the skin, and then this is more of a post-surgical issue with lymphedema, where people tend to get a lot of seromas, which is just a collection of fluid after surgery. So something that needs to always be addressed with that. Other complications, which we already mentioned about this, but just by virtue of having lymphedema, it puts you at a high risk of getting cellulitis, which we know are just bacterial infections of the skin itself or subcutaneous tissue, very commonly caused by group A hemolytic strep. Usually, symptoms you see with this is just increased pain, warm to the touch, that erythema, especially when it's spreading. And then sometimes they'll get induration or formation of blisters. Usually, this is something that needs to be addressed very urgently before it becomes more of a bigger problem. Another complication they can get is more of infection in the lymphatic vessels itself, which is lymphangitis. And that usually presents more as kind of a linear spread of like red streaks that kind of goes up the limb, almost following the trajectory of that vessel. So it looks a little bit different than cellulitis in that respect, but something to always look out for with people with lymphedema. Another important complication of lymphedema is that lymphatitis that usually get, especially people with stage 3, they get the swollen, thick, distorted limbs with the discoloration. And it's always something that needs to be managed properly, especially managing the expectations with people like this. You usually see people kind of hoping that this would go away. This is usually a chronic thing that you can kind of manage to the best of your ability, but this is going to be a lifelong permanent thing that will not go away. And then, besides just the swelling in the limb itself, you get this papillomatosis that you get, which is just firmed, lumpy projections on the skin that gives it that cobblestone-like appearance we've kind of alluded to before. Um, and this results mostly from dilation of lymphatic vessels and causing that inflammation that makes the vessels and the tissues very fibrotic. So you get this cobblestone appearance that can be disfiguring, but it's usually something that's very permanent with later stage lymphedema. And then other complications to also know about. This is more rare, but you can get basically lymphatic cancer from longstanding lymphedema. So you can get lymphangiosarcoma. This is usually more common in people who've had radiation treatment. So thinking about people who've had mastectomies for cancer or have had other kind of surgeries that are cancer related and end up having radiation. Physically, this will appear, as more of a red or purple discoloration of the skin, but then it usually kind of progresses to more of a crusting ulcer and then becomes more necrotic. So, just if you see an alarming type of wound in a patient who has a history of cancer and had lymphedema, it's usually something to be very, very proactive about it. And especially when you see the skin changes and the ulcer forming, they would need a very, very urgent referral to an oncologist just to evaluate and treat that. And then we kind of alluded to this as well, the lymphorrhea that you can get, which is just that weepiness that you get with patients with lymphedema. And it just happens just because of the disruption in those lymphatic vessels and a lot of pressure that just causes lymph to kind of seep through the skin. And then we'll have a next polling question at this point.
We'll give 10 more seconds for everybody to answer, and then I'll share the results.
Okay. So that's good. And obviously, we'll be talking more about this as we kind of get further in this webinar. But of course, it's a very important component of lymphedema management. So I think you've come to the right place, so we can kind of discuss a little bit more about this. So, all right, so we'll move on to. So we'll talk more about lymphedema prevention. And just as a thing about this, so this is really important if this can be identified early enough to start addressing so that it doesn't get to those late stages. Because, like we talk about, when it gets to those late stages, the skin changes are irreversible. A lot of the features you have at that point are irreversible. So if you can prevent and take care of things before it ever gets to that level, that's usually very beneficial. Important part of prevention for lymphedema is really good skin care. Usually kind of making sure you have a good moisturization of the affected limbs to prevent, dry skin and cracking. It's important. You want to be utilizing sunscreen and bug repellents as well. Washing the skin daily with a pH neutral soap and then drying it thoroughly is also important. And then monitoring skin folds, making sure you're not retaining any moisture in there. You don't have cuts or scrapes that can become a problem, and that addressed properly is also important. And then another important factor as far as moisturizing is using lotions and ointments that do not have fragrances or scents are very important, just so they're very gentle on the skin. And especially using things that are free from lanolin, or basically things that are not occlusive emollients, are very important when doing skincare with patients like this. So you really want to be careful with like those mineral-based products that can kind of block the pores, because usually those kind of like, even though they are very good for preventing dry skin, they would end up causing more trouble in patients who already have kind of a compromised skin to begin with. So very, very good meticulous skincare is very important in patients with lymphedema. And again, here, this is just mentioned that many of the interventions to protect are kind of based on common sense. You really just want to prevent injury to that affected limb. So like I just mentioned here, using an electric razor versus a manual one is usually a good idea, because you tend to cause less injury to the skin. And then this just mentions about wearing gloves when gardening and washing dishes. It's just taking all those precautions that you can, that are a little bit more common sense, just to really, really protect your skin. And then another important thing too is just avoiding extremes of temperature. So you want to avoid prolonged exposure to heat, such as hot tubs and saunas. Here it just mentions you don't want to be there longer than 15 minutes, but depending on the patient too. With an older patient, 15 minutes might be too, even less than 15 minutes might be long. So you kind of just want to be proactive and not exposing for certain periods of time to extreme hot or cold. And just very overall being very mindful that you already have a delicate skin situation when you're someone with lymphedema. Other things you can kind of do to help prevent lymphedema, especially if you're at high risk, is doing activities that kind of promote lymphatic flow. Avoiding placing your limbs in any gravity dependent position for long times will be very, very helpful. So kind of keeping those legs elevated. Even if the edema doesn't go away, it still helps with improving your flow, not just lymphatic flow, but your venous return. So that will be very important. Avoiding, constricting clothes, important as well. Managing your weight, not lifting things too heavy, avoiding rapid altitude changes also go a long way. And then exercise, which is good for everything, is also very, very good for promoting good lymphatic flow. You want to tailor the exercise to something that, the patient can keep up with. If they're get into fatigue, they will not be able to maintain this exercise program, and that would defeat the purpose. So it has to be something that's tailored to the patient. And that's where usually it's helpful when you can get therapists involved in things like this. And then utilizing very, very good wrapping bandages and compression stockings to kind of help promote lymphatic flow and drainage is important in preventing lymphedema as well. Moving on to lymphedema management. So the goal with lymphedema is really to move a lot of the trapped fluid that's kind of stuck in that interstitial space just because you have a compromised lymphatic system. And you're trying to get rid of that edema and restore as much as possible of the limb shape as you can. And then obviously preventing any infection. So talking a little bit more specifically about compression. So the standard treatment really for lymphedema, it's procedure which is usually a specialty of lymphedema specialists. It's called complete decompressive therapy. And this is, a program that they have that includes 4 components. So very importantly, they do compression and massage therapy with that. They do lymph drainage exercises, they do manual lymph drainage, and then they do skin care and nail care. So we'll talk a little bit more about this in the next few slides, but it's a very, very important. It's the standard. It's what those specialists do very, very well. But other things that you also want to involve in your lymphedema treatment is you can also use intermittent pneumatic compression devices. It's usually something that they'll have a schedule for that, and they'll do that a few times, a couple of hours a day, just to kind of help reduce the amount of swelling they have in the extremities. Physical therapy with a very good exercise program and doing the exercises while you have compression bandages on is also important. And then, as we just talked about, very, very good skin care and nail care, keeping the limbs elevated. Dietary kind of choices that you have, especially things, trying to maintain a healthy weight is very important for lymphedema treatment as well. And then avoiding long periods of sitting, standing, or crossing the legs. It's also another important thing with this. So talking a little bit more about complete decongestive physiotherapy. So like we were just talking about, so this is the gold standard for the management of moderate to severe lymphedema. Usually they have a certified lymphedema therapist. A lot of times the occupational therapist or physical therapist or nurse practitioners that are trained to do this. So really a big component of it is it's a very specialized massage that's designed to stimulate lymph vessels and kind of break up some of that subcutaneous fibrotic tissue that forms in lymphedema, and then kind of redirect some of that lymph fluid away from the extremities, kind of back towards kind of the central system to kind of get you better lymph flow. Again, those 4 components of it is doing that manual lymph drainage with the massages, doing very, very good compression bandaging, very good exercise regimen, kind of incorporated with the compression, and then very good skin and nail care. Complete decongestive physiotherapy is usually done in 2 phases. There's an initial reductive phase where that's when the first see the patient and you're trying to establish them to kind of get things going. And then there's a maintenance phase. To elaborate more about those 2 phases. So that first phase is the manual lymph drainage phase, where for about 3 to 8 weeks, they'll have sessions where they'll do the massages. There's very good videos on YouTube. If you can really find a good one, I would recommend even trying to see about this. But what they do is they have specific points depending on the limb where they know where to massage the right nodes and the right parts of the limb to kind of break things up, kind of push that fluid right in the right direction. And, by doing that, they're kind of activating the lymphatic channels kind of from a distal part of the limb towards the central part to kind of mobilize the lymph kind of more in a central direction. Um, is usually they usually do that along with range of motion exercises. They use short stretch compression as part of this, and it's usually kind of the first step, that phase one, where they kind of establish things to kind of get that treatment going for it. And of course, as part of this, always pay close attention to your skin and your nails to make sure they're doing very good skin and nail care. And then phase two is the maintenance phase, where once they've gotten they've done that phase one, they've gotten some reduction in the limb size. This is usually kind of them trying to maintain and make sure that they're doing very good treatment with a compression bandage. And this also usually involves kind of a self or educating the patient and getting them more involved with what kind of exercises they're doing and what kind of skincare they're doing, just to make sure that they keep that edema, that lymphedema or that edema at a manageable level. And then it will be also important to mention there's some other adjunctive therapies that you can do for lymphedema. There's a selenium therapy, which the theory behind it is just that with lymphedema, you have a lot of excessive free radicals just as part of the inflammatory process. And selenium, which is an antioxidant, can kind of be key in consuming some of those oxygen radicals and would, decrease the amount of damage that you have to the lymphatic system. And so that helps in that way. There's also hyperbaric oxygen therapy, which can be very helpful in stimulating growth of new lymphatic systems. So there is some use of that in patients, in breast cancer patients who have lymphedema, to try to get the condition to be better. And then there's also the use of kinesiotaping, which is, the tape that you usually see used in athletes. Using that, a good wrapping technique with that is also helpful in reducing swelling by improving blood and lymphatic flow and the extremities. So this is just some adjunctive therapies that could also be used. There are some surgical interventions that can be used in lymphedema. These are not very commonly done, but it's important to know that they exist out there. There is a it's a big word, lymphatic bypass surgery that can be done. It's really just a microsurgery that's done to kind of relieve blocked lymphatic vessels by connecting them to a nearby vein. So that way it drains a little bit faster without going centrally. You just get the lymph fluid to flow into a vein and kind of get back to the body's circulation that way. Other surgeries that can be done is you could do a vascularized lymph node transfer, which basically taking a lymph node, functional lymph node from one part of the body and put it in a dysfunctional part to kind of restore some of the typical function that you get in there and kind of help with drainage. And then there's a suction-assisted protein lipectomy procedure that can be done. And this just involves removing subcutaneous fatty tissue through kind of a liposuction procedure in the affected limb. It's a very minimally invasive type of procedure, and it's being done in some places to kind of help reduce lymphatic volume and kind of increase blood flow in that limb. So there are some surgeries that exist out there that can be done, but again, these are not very common, and a lot of times in the patient population that we see in the nursing homes, these are usually not surgeries that we're referring people for. And then, of course, there's the all-important wound care. So a lot of times when we see patients, especially in those late stages, where they end up with ulcerations from the lymphedema, very, very important, very, very careful and good wound care is something that we pay close attention to. Of course, when the need arises, we debride any non-viable tissue. Surgical debridement is the preferred method over enzymatic debridement just because it gets rid of that dead tissue a lot faster. We always want to keep in mind that always want to keep moist wound healing technique in mind. And this just stems from the fact that though we do have a lot of drainage in the limbs, we want to have a good balance between not drying out the wounds too much. So where the need arises, using non-adherent dressings is important, or if there's too much drainage, using very absorbent dressings and foams can be very, very helpful. Um, Using antimicrobial and antibacterial dressings is also key. Just trying keeping in mind that cellulitis is also a big problem in this population of patients, and you always want to have something in place that kind of reduces the risk of that. And then, of course, very important is the kind of compression wraps and bandages that we're using for this. You always, with your wound care, incorporating that with very good compression and really just having good compression with every aspect of the care, with therapy, with everything and that you do with these patients. Talking a little bit about pharmacology and lymphedema treatment. Some of the medications that we can kind of incorporate into the treatment for this, talking about retinol-like agents, those can kind of be helpful in helping normalize skin changes in people with lymphedema. So using things like acitretin and topical tazlorodine can be helpful. Anti-helminthic agents can also be very helpful depending on kind of the reason for the lymphedema. In the right situation, that's something that you want to apply. Things like albendazole and mebendazole will be helpful. Good skin care with very, very well picked out topical skin agents are very important. Again, alluding back to what we talked about earlier with not using occlusive emollients and using things like ammonium lactate and topical urea. Antibiotics, when we run into problems with infection, are very helpful. And diuretics actually are not very, very beneficial in lymphedema. Usually, because the issue is more of a problem with either lymphatic drainage or kind of a structural problem, lymphatic problem, addressing that more from compression is usually a better way to handle this than just trying to reduce the volume with diuretics themselves. So they tend not to be very beneficial with lymphedema. Something worth mentioning here is the Lymphedema Treatment Act. So historically, it's been a challenge with treating lymphedema because a lot of the treatment garments that you can order for this were not covered, but this changed a few years ago with a federal law that was passed in December of 2002 that allowed coverage for compression supplies for lymphedema. So this began in January 2004, and so Medicare will pay for compression garments for daytime and nighttime treatment for lymphedema. So up to 3 garments for the affected body part every 6 months, and up to 2, that's during the day, and then 2 at night for every 2 years. So it's just an important thing to know that now you get more coverage with treatment with compression treatments for lymphedema, so you can feel more comfortable prescribing this for patients. And then we'll have the last set of questions.
And this should be the short answer questions, so we'll give everybody a little bit of time. We'd just love to know what are some topics you'd like to see next year for these education series.
right.
And you can go ahead and move on, Dr. Fotong. I'm not sure it's going to show those results since it was short answer. So,
Okay. All right. So that concludes a webinar today on lymphedema. Just an announcement that there'll be no webinar in January. That's next month, but there'll be one in February, on February 4th, and the topic is going to be about peripheral artery disease. And I will hand it over to Lauren or
Yes.
at this point.
Now, yeah, thank you, Dr. Votong. We'll move on to the question and answer portion. So just a reminder, if you have a question, feel free to throw it in the chat or in the Q&A section. But we do have 5 minutes or so to answer some questions. So I do have a couple for you.
Yeah.
First question we have is, do you recommend podiatry for lymphedema patients?
So that's a very good question. And I would say yes. If you do have access to it, especially in the facilities, that is an excellent idea. Just as part of that whole holistic approach to it of doing very good skincare and nail care, podiatrists can be very helpful. They have all the specialized training to take very good care of the nails. So yes, absolutely, yes, yes, yes. Have the podiatrist involved, so they can help with that part of taking care of it.
Awesome. Um, we just got another question on uh to something about compartment syndrome, but I'm not understanding the question. So um
I believe that was their answer to the last question of what other
oh,
topics.
I understand. Okay. Got it. I apologize. Okay, so next question we have is when would you encourage patients to see a certified lymphedema therapist versus treating in-house?
Oh, okay. So that's a good question. And as a short answer, at any so the lymphedema specialist will come in really handy when you have patients with very severe disease. Um, I would just say generally, uh, I'm a strong believer in loading the boat. If you do have access to a therapist that you can get at any point in the lymphedema journey, definitely get them involved. If you can get them to the clinic, if you know that usually it's difficult because there's not a lot of them around. Early on in the disease, it's reasonable to manage them in-house. When you get to any patient who's, I would say stage 2 and stage 3, where they're having severe disease, that would definitely be very key to getting a lymphedema specialist involved, especially if you can find one. But generally, if you can get them at any point in the journey and just have them as part of the kind of the multidisciplinary team that's taking care of the patient, by all means get them involved. So more key kind of later stages, they'll get a lot of benefit out of that because they can. That's when they'll usually need more of the CDT treatment. But early on, if it's subclinical or stage 1, and you're comfortable managing that in-house, it's okay to manage that. Once you get to a stage 2 or 3, definitely try to get a specialist involved.
Awesome. I think we have time for one more question, Dr. Fotong. So last question, should nurses avoid blood pressure checks, injections, or blood draws on any affected limbs?
That's a very good question. So it would have so the answer would be, yeah, generally yes. Of course, it will kind of depend a little bit on the clinical picture, but yes, if a patient is having um, severe, significant lymphedema in an extremity, I would say definitely yes. You want to avoid blood pressure checks or avoid anything that really manipulates with them in that extremity. I'm assuming they're talking about someone who has upper extremity lymphedema, usually typically people who are post surgical. So yes, you want to avoid doing any kind of procedure or doing any kind of manipulations of that sort on that limb. But to make the answer complicated, you would have to kind of take that a little bit on a case by case basis. But yes, overall, you want to avoid that limb.
Wonderful. I think that's the only time, or that's the amount of time we have. We only have about a minute left. Um, but unless there's any last minute questions, um, but yeah, I think that's it. Thank you
Or
everyone
there's
for
one
attending.
more question that popped up if we have a
Oh,
second. Uh,
Sure.
they, oh, answer to the last question. Nutrition interventions for patients with lymphedema, nutritional needs for lymphedema patients with and without wounds.
okay.
Sorry, the question is what would be good nutritional recommendations for patients with without lymphedema wounds?
With lymphedema in general. Yep.
So this is where obviously involving a very good dietitian will be involved. What I can say is, without getting into any specifics about what you can eat and what you can't eat, but just a healthy diet that kind of it's focused on trying to get you to a good weight is very important for that. But definitely, you want to try to involve your dietitian and making sure, obviously, you're eating a well balanced diet. Um, Similar kind of also recommendations for things that will kind of prevent edema. So if you're thinking about uh, typical what you will encourage for um, people, low salt diet and things like that. But typically, you want to defer to a very, very well trained person, such as a dietitian, to kind of help you with that, with the focus of getting a very balanced diet that does not promote edema. And that usually helps in situations like that.
Awesome. Well, that's all the time we have. Thank you everyone for attending. I hope you guys all have a fantastic holiday season and a happy new year, and we'll see you guys in February.